Welcome back to Therapeutics. In this block, we're going to review fluids and electrolytes and briefly talk about nutrition support management. We'll also very briefly review acid-base disorders, and we'll talk a bit about nutraceuticals, vitamins, minerals, and a bit about parenteral and enteral nutrition. So let's first look at the issues we have for fluid electrolytes for adults and some key issues here. The first question we're going to focus on is what fluids and how much of those fluids. We'll then focus on sodium, then potassium, then calcium, phos, and magnesium, and then we'll follow up with what other issues we have. In practice, we often think about how much fluids, and particularly what is the basic requirement for most patients within 24 hours for the amount of fluids or volume of fluid. To think about this, we need to think about the nature of fluids and where fluids are distributed. If we think of in typical adults that 60% of the total body fluids are intracellular, 40% being extracellular, and then the sub-breakdown of that extracellular fluid, about a quarter of that in the intravascular compartment, and the rest of it being interstitial. So if we're looking for a typical adult fluid requirement, we're going to usually look at 100 milliliters per kilogram for the first 10 kilograms of body weight, then 50 milliliters per kilogram for the next 10 kilograms, and then for everything over 20 kilograms, 20 milliliters per kilogram. And then we're going to make modifications if someone's febrile or if they've had excessive fluid loss or if they have a thermal injury. So let's do a couple of, or an example with a case here. SK is a 46-year-old female who weighs 70 kilograms. She's in the hospital with acute cholecystitis. She's currently NPO. What is her baseline fluid requirement? So we'll look at some different numbers here. And as you look through these, see if you can estimate or guess what the nature of her need is going to be for fluid balance. And we're going to calculate that out as, in general, about 2,500 mils per day. Let's look at how we arrived at that. So if we add, for the first 10 kilograms, 100 milliliters per kilogram, so that's a liter. And then for the next 10 kilograms, a half a liter. And then for the remaining 50 kilograms, another liter, and that's how we got to 2,500. She's not particularly febrile. That's not a concern. She hasn't had any major fluid losses with vomiting or diarrhea, so we didn't need to add on to that for either of those factors. So then let's look at what fluid losses are typically seen in a typical patient and what fluid loss and how much we think of as we look at this. Typically, the kind of things we're looking at are whether or not there is a urine loss, a nasogastric suction, for example, small bowel, sweat, or diarrhea. And then we'll see which electrolytes we tend to lose or how the loss of those particular fluids affects things. So with urine loss or excessive urination, we're more likely to see loss of sodium and then some potassium. With nasogastric losses, a lot of sodium, a lot of chloride, some potassium as well as seeing a lot of change in acid-base balances, so we need to make up for that, typically with the addition of chloride. We're also going to look at, in small bowel losses, we see some bicarbonate as well as some chloride loss, as well as mostly sodium loss. In sweat, a lot of sodium and chloride loss, and in diarrhea, sodium, and a lot of potassium loss with significant diarrhea as well. If we look at the fluids and where they'll go, here's a table, and we'll explain these a bit more in depth with a few graphics. But if we give a liter of normal saline, by the time it's fully distributed and administered, about a quarter of that is going to end up in the intravascular compartment. That's true for lactated ringers. That's also true for related agents like saline and lactated ringers. For D5W, we give a liter, and very little of that ends up in the intravascular space. Almost all of it ends up in the interstitial or intracellular space. On the other hand, albumin, most of the albumin we give, or all the albumin we give, really ends up in the intravascular space because it doesn't want to leave that space. And so when we have patients, for example, who have a risk of a third spacing, where we have a lot of fluids accumulating in other places like in ascites and liver failure, the advantage of something like albumin, at least short term, is that it stays intravascularly and expands the intravascular compartment. So while we don't use albumin all that much because it is a blood product and we weigh the risk and the benefit of giving albumin, and it's pretty short-lived when we give albumin. We only see the benefit for a day or two. But we will use albumin in situations where we have significant ascites, for example, with significant hepatorenal syndrome. So, for example, someone who has liver failure with ascites, a lot of fluid in the abdominal peritoneal cavity, and yet the central compartment is dry, the vasculature is dry, and we want to keep fluid just there and not contribute to more ascites. In fact, giving albumin preserves perfusion to the kidneys and reduces the risk or improves symptoms for or presentation in hepatorenal syndrome, where the patient is otherwise centrally dry and has a lot of third spacing going on. So albumin has a potential role there. And head of starch, at the last component here, rarely do we see that used. Complications with bleeding and with head of starch, and so clinically we don't see that used in practice very much. So when you have someone who has intravascular volume depletion, the kind of classic things you'll expect to see, and this should be sort of significant, consistent with what you've learned so far in the curriculum, this should all make sense. We expect to see tachycardia and hypotension. Also orthostasis, you're likely to see an increased BUN to creatinine ratio, dry mucous membranes, decreased skin turgor, reduced urine output. Often patients will have orthostasis with dizziness. And after you give a half a liter or a liter of fluid, you'd expect that the blood pressure would begin to improve in the right direction and the heart rate would hopefully begin to go down. So deciding what you replace with, which fluids. Do we use crystalloids or colloids? So crystalloids being saline or lactated ringers or D5, and these maintain osmotic gradient between the extracellular and intercellular fluid, and depending on whether it's saline or whether it's dextrose, how much of that will end up remaining in the vasculature, as we saw in that table just a minute ago. Colloids, the most significant one I think clinicians would consider using is albumin, will increase oncotic pressure and not only keep fluid in the intravascular space, but will also potentially even draw fluid from extravalvular sites back into the vascular space. But these agents have more limited use, and of the three of the ones listed here, we don't really use dextran or plasminate very much in practice. Typically, if you're going to use them, it's albumin, and we use albumin fairly sparingly, recognizing the benefit is only short-term for hours to a day or two tops. It's a blood product, so there's the potential risk with all blood products for both potential hypersensitivity reactions, but also, even though the screening and preparation of blood products is good, in the back of our mind, we still always think about is there some unknown infectious process that could possibly be transmitted by albumin. So let's look at colloids, and when we give albumin, for example, as the classic colloid, where does it go? Well, this graphic, you'll see albumin in the intravascular space, and lo and behold, pretty much it will stay. In fact, not only will the albumin stay in the intravascular space and expand the intravascular space, it will actually draw some fluid from the intracellular and interstitial spaces. Free water movement basically going toward the intravascular space. For crystalloids, let's first look at normal saline. We first administer normal saline. Where does it go? It will begin to be transferred from the vasculature into the interstitial space, ultimately much of it going toward the intracellular space. even more, and then coming in equilibrium between the intravascular, interstitial, and intracellular spaces. Pretty much at equilibrium, you'll see with normal saline, maybe a third of normal saline will remain in the intravascular space, a third in the interstitial, and a third in the intracellular spaces. So saline is considered the classic volume expander we use when someone's dehydrated because it will go everywhere pretty much. So we see that equilibrium and basically, as we alluded to, where it will go. Finally, let's look at dextrose. We administer dextrose and let's see where D5 goes. It even more quickly will go to the interstitial and intracellular spaces. Continue to do that. Ultimately, a little bit may stay in the intravascular space, but if you need volume expansion of the intravascular space, someone who's hypotensive, then dextrose is not your go-to agent. Dextrose is going to primarily end up in the interstitial and intracellular spaces. So what we see basically in this sort of summary graphic of this and the next slide is you'll basically see that depending on where you want your fluid to end up, albumin just purely in the intravascular space and even drawing fluid off of the interstitial spaces, saline sort of in equilibrium in all areas, and dextrose primarily to the interstitial and intracellular areas. So when do we use albumin? Rarely, as we alluded to, when we want to draw fluid off the interstitial or intracellular spaces. It's a blood product with all of those risks, which we alluded to. Saline is the standard first go-to drug, usually for volume expansion, when we're looking at intravascular volume and interstitial and intracellular volume expansion, all three of those. So routinely, someone is hypotensive, whether it's hypertensive shock, whether it is other hypovolemic shock of some sort, particularly if the dehydrated saline, maybe lactated ringers will sort of distribute in a similar way that we see here with normal saline. These are really the go-to common agents you'll see used in most cases where you have hypotension and hypovolemia. D5, pretty much our goal is when we want to see interstitial and intracellular volume. We don't see very much intravascular volume. And we also have to be very careful about dextrose use in children in particular, because in children we can actually see significant hyponatremia. So we watch for hyponatremia whenever we use D5, and we're particularly cautious about how we use D5 or D10 in children and newborns, carefully watching sodium levels for excessive hyponatremia. Okay, so that gives you the sense of where we are. Let's now talk about a few other factors in fluid. First of all, tonicity, or is it isotonic or not? This is a real important consideration in volume replacement because we generally want the tonicity of the fluid we're using to be identical or similar to what you would see with red cells or in the blood. And so typically we're looking for about 300 to 310 milliosmoles per liter. We also think about the molecular weights valences of common electrolytes. They're listed here. We don't, as clinicians, have to do a lot of math here, but important to sort of hark back a bit on what you remember from basic chemistry. In these electrolytes and valences and equivalent weights are sometimes used in how we assess quantifying the doses and amounts that we're going to give, particularly when we're trying to equilibrate a patient who has electrolyte abnormalities. We're also looking at osmoles, which is the degree of osmolality related to a particular fluid. So when we add salts to a solution, we change the osmolality. This becomes a concern when we're using particularly hyperosmotic preparations. Those include particular preparations like 3% saline. We'll talk about that a little bit later. That is hypertonic and really causes a lot of fluid shifts dramatically. We need to be careful about that. We also have to be careful about hypoosmotic solutions where the osmotic pressure is just too low and results in sort of danger. There's also some conversion tables that are listed here, but truthfully in practice you probably won't have to do too much of that. Here is a couple of graphics here though that will indicate in a hypo, iso, or hypertonic solution what red blood cells will do in that solution. So the reason we can't give just plain sterile water as an IV fluid is that it is hypotonic. It doesn't have enough isotonicity in it. And what will happen is that water will cause swelling and lysis for, among other things, red blood cells. And so we never give sterile water for injection as a solution, particularly as a fluid solution. I mean, the only limit we have with using sterile water for injection and why they even make such an animal is when we reconstitute a vial of a drug in a small quantity and the isotonic or the osmotic pressure of that solution once you add the sterile water for injection usually is close to isotonic, and that's a non-issue. But we wouldn't give sterile water for injection as an infusion or directly give that IV because of the potential risk for this swelling and red blood cell lysis. Most often when we're doing fluid replacements, we are searching for an isotonic solution, which is typically normal saline or 0.9% sodium chloride. And here the fluid pressure going in and out of the red cell is equilibrated, and you don't see any red blood cell swelling, lysis, or shrinkage, as we'll see with a hypertonic solution in the next slide. With hypertonic solutions, a classic example is 3% normal saline, you risk having the shrinkage of the cell. And the only time we use 3% saline, and it's rare, but we'll talk about it in this slide deck block, is for a patient who has significant hyponatremia, particularly when their serum sodium level is below 120 and they're symptomatic, typically with CNS or mental status changes. So in summary, here is the sort of graphic that compares a red cell in a hypo, iso, and hypertonic solution. And what we're really looking for here, and what we shoot for most of the time, is to use an isotonic solution. As we look at the composition of body fluids, we have to think about whether it's a cation or an anion, and whether it's located primarily intracellularly or extracellularly. And if it's extracellular, is it in the plasma or the interstitial space? So we think of the two most important cations we think of right away is sodium and potassium. And the thing to think about is sodium is extracellular and potassium is primarily intracellular. And so if you look at what is in the plasma, a typical normal sodium level is going to be something in the range of 140 milliequivalents per liter, and a typical potassium serum level or plasma level is going to be about 4 milliequivalents per liter, keeping in mind that most of the potassium in the body is intracellular and most of the sodium in the body is extracellular. There's also amounts for magnesium, calcium listed here, where calcium mostly extracellular and magnesium mostly intracellular. And then for the anions listed at the bottom half of the slide, they break down as well, where most chloride is extracellular, and that's true for bicarb as well, where most phosphate is located intracellularly. Keep in mind also that the sum total of cations should equilibrate with the sum totals of anions. And the only times that does not happen, and what we consider an anion gap, is a situation, for example, when there's something else in the blood that is contributing to the offset of cation and anion balance. Most often we see this in situations of either ketoacidosis in a patient who's diabetic, or you may see it occasionally with certain ingestions of other substances like methanol in toxicology. In addition to the intracellular amounts being equilibrated, the extracellular anions and cations again should equilibrate. And then let's look a bit at our comparison of IV replacement fluids. And we're looking really for something that is isotonic, which is normal saline. Close to isotonic is D5W. Half normal saline is about as dilute a solution as we're going to want to give and still not have red cell lysis. We would not give water for injection, for example, as we alluded to earlier. And 3% normal saline, typically it's very hypertonic, and we would give it only in a situation where it's being directly infused very slowly into a patient who is otherwise hyponatremic, significantly hyponatremic. And then the breakdown of what is intracellular versus extracellular fluid is in the second and third columns here. And the remaining will sort of give you the amount of sodium or chloride or dextrose in each of those situations. The other issue that we think of as free water is whether or not it adds or takes away from free water when it's administered. And so you'll see that 3% normal saline, for example, really draws extra free water toward it. And so it's a negative free water balance per liter administered. Saline is neutral. Half normal saline is positive, about 500 per a liter, and D5 is all free water. So if you're in a situation where you need to give a patient free water, then D5 may make a lot of sense, but you're going to keep an eye on watching for hyponatremia, and you're going to watch for, particularly in pediatrics, and you're going to watch for other factors as well as hydration status and volume expansion as it relates to the intravascular space, which D5W does not really do. So let's now focus a bit on some of the specific electrolytes and then the abnormalities that can occur with either too little or too much of each of them. And we're going to start off with sodium. As we look at this big table, keep in mind when we look at sodium, what is intracellular versus what is extracellular, and we're going to really focus on that component that's highlighted here in yellow. So sodium is primarily an extracellular ion. Its normal range in the serum is usually somewhere between 135 and 145 milliequivalents per liter. And keep in mind where sodium goes, so goes water. So when we look at fluid shifts in patients, how we use sodium, where sodium goes in the body will often explain where the fluid goes as well. So we need to kind of keep that in mind. So let's first talk about conditions where we have a low sodium hyponatremia, and these are broken down into isotonic hyponatremia, hypertonic hyponatremia, and hypertonic hyponatremia. The first two listed in the slide, the isotonic and the hypertonic hyponatremia, are both fairly rare. Isotonic hyponatremia might be secondary to significant hyperlipidemias, or we sometimes see this with the use of the sedative agent propofol when we give it longer than just for a surgical procedure. Sometimes we see this in the ICU setting, but not all that common. Similarly, hypertonic hyponatremia, pretty rare. Typically, this is going to be related to significant hyperglycemia or mannitol administration. We might see this, for example, as a component of ketoacidosis, but we don't see it all that much. The situation we're going to most often see with hypotonic hyponatremia is someone who usually has been pretty dehydrated for some reason or another, and the subtypes of hypotonic hyponatremia could be related to low volume. They've lost a lot of fluids, particularly diarrhea, vomiting, sweating, or lack of hydration. Euvolemic, where the free water intake is increased, but they haven't enough sodium. This is also sometimes seen in the syndrome of inappropriate ADH secretion, or SIADH. And then hypervolemic could be seen in patients with heart failure, ascites, cirrhosis, or kidney failure, where patients hold on to a lot of extra free water, but overall their serum sodium level is low. Here's a table that, in a sense, is a little more specific on describing these. for descriptions with examples and how diagnostically that might be managed. I encourage you to take a quick look at that. So the symptoms of hyponatremia typically, for mild hyponatremia where we're still above a serum sodium of 120 to 125, some patients may exhibit nausea, maybe malaise or fatigue, weakness. And typically our management is going to be just giving a patient maybe if their fluid status, if they're a little bit dehydrated, giving them a half a liter or a liter of saline, something like that, and watching where they are, depending on where the patient is and what their comorbidities are. It's when serum sodiums fall below 120 that patients may begin to have symptoms, and most often those symptoms are central nervous system symptoms. They might present with headache, severe lethargy, they might be obtunded, or if they're alert and awake and ambulating, they might be unsteady. They also might have a lot of confusion, and when it gets below 115, we're very concerned about the risk for delirium, seizures, coma, respiratory arrest, even death. And so severe hyponatremia is really a concern. And occasionally we see this happen more slowly in patients, and sometimes it's a more quick onset. We need to be careful, though, in how we reverse that and making sure when we reverse that hyponatremia, we do it carefully because of the fluid shifts that happen with sodium. So keep in mind that the hypotonic, isotonic, and hypertonic states each have effects on red blood cells. We've already sort of alluded to that already. So let's look now at the treatment of hyponatremia. First of all, you need to determine whether or not the patient is symptomatic and if their serum sodium is below 120. So if they're above 120 and they're not overly symptomatic, then typically what we're going to do is look at just normal saline, titrate where they are, try to look at why they were hyponatremic, and correct the underlying reason. Normal saline is most often going to be our agent of choice, particularly when the sodium is above 120. We can use 3% saline, but 3% saline is considered a high-risk drug per the Joint Commission on Accreditation of Hospitals, the Institute for Safe Medication Practices. This can be, if 3% saline gets grabbed, a bottle of 3% saline gets grabbed by accident by a nurse in place of normal saline and administered at a standard rate that we give normal saline, you can actually have a fatality associated with that. So we're going to usually limit 3% normal saline, and most hospitals really limit how it's even accessible. Really, it's only accessible by the pharmacy on a bag-by-bag basis. Pharmacists usually will work with the team to confirm, do you really want this? But we're going to reserve for patients who have a serum sodium below 120, and they have symptoms, particularly if they're having seizures or change in mental status, or they're comatose, or particularly lethargic, and they have, particularly if they have high urine sodium losses. Those are really going to be the patients we're going to look at it being used in. The other issue is that we have to be very careful about the rate of a 3% saline solution because we don't want the serum sodium to rise too quickly. Keep in mind, when we see a rapid shift in sodium, you're going to have fluid changes as well. And so what you don't want are major shifts in fluid across the blood-brain barrier and to other compartments or areas where the patient could have major fluid shifts. And so we typically don't want to see a greater than a 12 milliequivalent per liter rise in serum sodium over 24 hours, and usually not more than a 1 to 2 milliequivalent per liter per hour. So we need to do that carefully if we're giving someone 3% saline in particular, but even with normal saline in replacement, you probably want to get serum sodium levels frequently. If you're starting 3% saline, it's not out of line to consider serum sodium levels even every 2 hours to see where you are initially, and then maybe every 4 hours until you complete and correct the sodium to where you want it as a goal, at least above 120. And that rapid administration, as we alluded to with rapid shifts, particularly a concern for cerebral edema, for pontine myelinolysis, or seizures, or pulmonary edema. All of those are major complications associated with rapid administration of 3% saline. So that's key. Don't forget. Don't sort of ignore that. That's a big issue. So let's look at a case. TS is a 68-year-old, 60-kilogram female with confusion. She has serum sodium of 111. She's euvolemic. They question syndrome of inappropriate ADH secretion. Nephrology seeks to get her serum sodium at about 120 per liter over the next 24 hours using 3% saline. So the first question is 3% saline appropriate for this patient? I want you to look at this patient and see if that, in your mind, is it appropriate to use 3% saline? And you should have thought yes. I'm hoping you think yes. Why? Because her sodium level is below 120 and she is having CNS symptoms with confusion. So she is a candidate for 3% saline. So we have a couple of choices here. Is it 225 of 3% saline over 18 hours? 525 of 3% saline over 18 hours? 675 milliliters of 3% saline over 24 hours? Or 1,300 of 3% saline over 24 hours? How do we calculate that? Well, we typically want to make sure that we don't go more than 12 milliequivalents in 24. So our goal in 24 hours is typically going to be 9 milliequivalents per liter to be replaced. We can look at the nature of solutions. Sometimes we can do sort of calculations to figure out how much 3% saline we need in part, looking at these graphics and these numbers. And let's look at some data for this case now. So we're looking at a 24-hour 3% saline volume. What's our desired rise divided by some numbers listed here, the sodium concentration IV fluid to be infused less the serum sodium concentration divided by total body water plus 1 liter. And I'll tell you in practice it's kind of hard to do these on the fly. And total body water listed here, typically for a female, it's going to be somewhere between 0.45 and 0.6 times their weight in kilograms. Typically, in this case, we're going to probably use for this patient somewhere between 0.45 and 0.5. So we plug in the numbers. And lo and behold, we're looking at just under 700 milliliters of 3% saline over 24 hours. Now, I will tell you that that's the classic way to do the calculation. Most clinicians will use a calculator online. And as we've alluded to on other parts of the curriculum, Global RPH has such a calculator. I'd encourage you to consider playing with this one. And these are helpful to give you some guidance as far as what your goals are. Typically, you're going to look at Global RPH, and you're going to go to the calculator. When you do that, the medical calculator, you're going to look for the calculator that's going to help you with 3% saline, hypertonic, and normal saline calculation. And the calculator will then give you some guidance as far as the patient's data. So we're going to enter the patient's data, what their serum sodium is, those elements being entered in, and our target usually is going to be to get them up to 120. So at 120 is where we're going, and lo and behold, we'll move forward. It's going to give you a recommendation of how much to administer over what period of time. So as we look at data, you could find, for example, the data is going to help assist you or the calculator is going to help assist you in determining what to use. And lo and behold, it'll give you, a couple of different ways to do it. But for the most part, what you're going to find is that it will give you a desired infusion rate to administer over what period of time. So in this situation, they looked at infusing more like 525 mils per to get you to your goal level. So you could make, doing a couple different calculations, maybe looking at a couple of different assumptions that are made. In this case, we'd look at something like 525 mils over 18 hours or 675 over 24 hours. Either of these are reasonable alternatives to consider. I'd encourage you to spend just a couple minutes, just go through the calculator, just play with them a little bit and get the sense of how we would figure that out. But for the most part, what you're shooting for is a goal within how much do you want to get it up over what window of time to get to the goal of 120. And once you get to 120, typically we're going to switch them to normal saline. So 3% saline is going to be limited again to patients who have a serum sodium less than 120 and who are symptomatic with CNS changes. Let's say they're 117 or 118, they have no CNS symptoms, then whether or not we use 3% saline might be a judgment call, but most clinicians would try to correct that modestly reduced sodium or significantly reduced sodium, but with no CNS symptoms, just with normal saline, not use 3% sodium chloride. So either of these responses are reasonable choices. Let's now talk about treatment of syndrome of inappropriate ADH secretion very quickly, not to go into too much depth about it. But typically there are drugs that also predispose a patient to syndrome of inappropriate ADH secretion. The most notorious of these is the anticonvulsant, antiepileptic carbamazepine or Tegretol. And we typically would manage that with just reducing free water intake for the patient. There's a couple of different treatments that can be used. We can look at the Vaptans, we can look at DDAVP or democlocycline. All of these are not unreasonable choices. In some cases, we also look at urea being a modality of treatment as well. But those are some of the things we'd think of for someone with SIADH. All right, let's move now to potassium. As we think about patients with shifts in potassium, first of all, we want to think of what the normal range for serum potassium is. It's usually between 3.5 and 5. It's an intracellular ion primarily, so the serum levels are much lower than what the intracellular levels are. And you can find that there might be patients who might be significantly volume depleted in potassium, where the serum levels maybe are not as clear as how depleted they are, and the situation where they would be most depleted with potassium, but the serum levels may not reflect that, is in ketoacidosis, diabetic ketoacidosis, where the pH, the acid pH, drives some of the potassium extracellularly, and we're going to look at trying to drive it intracellularly as we correct that. So that we think of potassium as intracellular. Its levels, again, affected much by pH in the serum, and we're really concerned about what potassium does. It's going to be affecting muscle, particularly cardiac, and so we're going to worry with low or high potassium, primarily for cardiac arrhythmia risk, both with low and with high serum potassium. So our shoot is going to be we're going to aim for serum potassium between 3.5 and 5 milliequivalents per liter in the serum. And we're also going to look at pH balance as affecting the amount that's going to be intracellular or extracellular for potassium. So you may remember in basic acid-base balance, the primary issues with acid-base balance is metabolic acidosis or alkalosis, or respiratory acidosis or alkalosis. And then there's a compensatory process that if it's metabolic, then the respiratory tries to compensate. If it's respiratory, then the metabolic process tries to compensate. So let's look at what happens in alkalosis with pH. If the pH is 7, then you're going to see the shift of potassium into the cell, and so you're going to see the serum potassium levels go down. In normal pH of 7.4 in the serum, we're going to have an equilibrium of potassium in and out of the cell. And in acidotic states, a lot of that potassium gets shifted out of the cell. So as you think about our management in diabetic ketoacidosis with potassium, keeping in mind that while the patient may have an elevated potassium serum level in ketoacidosis, while their pH is 6.9 or 7, as you give insulin and as you give normal saline, you'll find that as the pH improves to normal, the serum potassium levels go down, and then they go down dramatically. And why that is while their serum potassium is early on elevated because of their acidotic state, they're actually potassium body store depleted because patients with ketoacidosis typically have had a lot of urination and loss of potassium over the prior 24 to 48 hours. So let's look first at hypokalemia. This might be reflected in impaired intake of potassium or not enough supplementation. Most often it's diarrhea or NG losses. You could have metabolic alkalosis with shifts to inside the cell. You could have renal losses in concurrent with a low magnesium. And many times it's drug-related, particularly diuretics, particularly the loop diuretics like furosemide. The risks, as we alluded to, are problematic with either low or high potassium levels. In low potassium levels, which we're talking about here, our biggest risk is cardiac. We see an ST flattening EKG with a wide QRS, and a low potassium is a risk for a patient for ventricular arrhythmias, particularly if they're also on concurrent drugs that prolong the QT interval or they're on digoxin. Non-cardiac effects of hypokalemia also include myalgias, weakness, and cramps, particularly leg cramps. And most of the time, as long as serum potassium is above 3.2, most patients are asymptomatic. The management of hypokalemic in adults is to correct the underlying cause. So, for example, if they're depleted from body store potassiums, correcting that, keeping in mind that the pH of the serum will influence what their true body stores are, whether or not you have to interpret the serum level of potassium in light of a pH if it's not normal. You want to keep their serum potassium above 4, usually most clinicians do, if they either have a cardiac history at all of cardiac arrhythmias or at risk for that, or on drugs like digoxin. And you want to also keep their magnesium levels in check too, particularly for their cardiac status. And you want to get a magnesium level, particularly if their potassium is below 30 and below 3, and as soon as you can if it's between 3 and 3.5. So the body deficits, we could calculate a body deficit for each milliequivalent per liter in the serum, assuming normal pH, serum pH. We would expect to see a loss of about 100 milliequivalents of body potassium, and so sort of it gives you sort of an estimate or calculation here based on how much that ends up being. And typically when we replace potassium, ideally, if it's not urgent, we're going to try to go with oral when we can, because oral administration is a lower risk for excessive hyperkalemic response to the administered potassium. But when it's pretty urgent in the hospital, we'll give diluted potassium. Usually 10 milliequivalents over an hour is pretty typical of routine in most non-urgent cases. So K replacement listed here. Typically, if it's 3 to 3.5, we give oral potassium chloride, and usually in the dose we'll give is somewhere from 10 to 60 milliequivalents as a single dose, and usually not much more than 60 to 80 per day. And you don't want to overshoot that, particularly in someone who might be older. You want to sort of weigh how aggressive we get and whether or not they're on concurrent potassium sparing or potassium losing drugs. If it's below 3, particularly how much below 3, we may start to consider IV therapy. And when we look at IV potassium, we usually will give anywhere from 10 to 20 milliequivalents per hour as a diluted solution. If it's a little more concentrated, you'll have to give it as a central line. And we never, ever, ever, ever give potassium IV push because that is fatal. You will see immediate cardiac arrhythmias and death. So it has to be diluted. Usually it's 10 milliequivalents in 100 milliliters or a larger volume. Sometimes we have a more concentrated potassium, but it's very irritating to the vein, and when it's more concentrated, we give it via a central or a PICC line, not a peripheral line. And we usually don't give more than 10 milliequivalents per hour. If we give more than 10 milliequivalents per hour, and this table indicates all the way up to 40, that's requiring continuous EKG monitoring. And usually in most hospitals, any rate more than 10 milligrams per hour is a patient who needs to be in the ICU with telemetry on board and careful monitoring. So here's some guidelines for IV replacement in a non-critical, non-telemetry care unit. You could give a large volume IV with 10 to 40 milliequivalent per liter, or in a total parenteral nutrition, maybe up to 80 milliequivalents per liter, at a rate up to 10 milliequivalents per hour. If you need to give mini infusions or a central line, you could do that, but usually on the floor, in a non-ICU setting, we don't go more than 10 milliequivalents per hour in most settings I've worked at. If you need to give more aggressive replacement of potassium, then you've got to put the patient on telemetry. For telemetry patients, you could go up to 20 milliequivalents per hour, and again, the same sort of solutions, peripheral or central, but it's the rate that's higher. And sometimes in urgent cases, we will, in an ICU setting, give more than 20 milligrams per hour, but that's only in an ICU or an emergency department where someone is very hypokalemic and you're carefully monitoring that, and your solution is dilute enough that it's not going to cause irritation to the vein, and your rate is via a pump that is consistently administered with no boluses. So in critical care, there's more guidelines here to be a little more specific. I'm not going to belabor that by talking about it, but you could look at that if that were the case. And then in enteral potassium replacement in non-critical situations, in enterally, we can give adults typically at a 30 milliequivalent Q3 hour if it's an immediate release oral formulation, or if it's sustained action formulation, 60 milliequivalents could be given as well. But we want to look at how much we're giving IV and PO and not overdo the amount of potassium we give a patient at any one point in time because of the risk for cardiac arrhythmias from hyperkalemia. Then there are some enteral guidelines for telemetry and critical care as well. So let's look at our third case. LF is a 76-year-old male who weighs 90 kilograms, admitted to a general med floor. His heart failure, he's on digoxin, he's on furosemide. So let's first look at the digoxin. His digoxin means that we want to keep an eye on his electrolytes carefully because low or high potassium, when dig is on board, can risk for cardiac arrhythmias. We also are looking at his furosemide, and that's going to cause a loss of potassium for him. So his serum potassium is quite low at 2.4. His creatinine is 1.1. So which of the following are appropriate interventions for him? And let's go through a number of them. Transfer him to a tele unit, order a mag level, get a dig level, add potassium IV, add potassium oral, get electrolytes. Which of those would you like to do? Okay, so as we think about this, let's go through them one by one. Transfer him to tele, yes, we want to do that. He's got a low potassium, he's on dig, we're risking ventricular arrhythmias with him, so tele makes sense. Yes, we want to get an add-on mag level, and we always get a mag level when the potassium is below 3. In addition, you could have the lab draw it, but if the lab already has a sample from that potassium that you're responding to, the lab, you can call down the lab or order what's called an add-on level, and they've already got the sample. You don't waste time in having somebody run up to the floor, draw the sample, run down to the lab. They can just run that test on the sample they've already got, and that saves time, and time is everything, because you may have to replace magnesium as well. We'll talk about that in a minute. We do want to get a dig level if he hasn't had one, because we want to know, is he dig toxic? If his digoxin level is already high plus a low potassium, we need to keep an eye on what his risk for arrhythmias are going to be. Yes, we're going to give him some IV potassium, 10 milliequivalents over an hour times 2 doses. Most clinicians are probably going to give like even more than that, probably 10 milliequivalents for 4 doses. If we're worried about arrhythmias and his risk is high, some folks in the ICU setting might give 20 milliequivalents per over an hour instead of 10 while he's on telemetry. Adding oral, yes. So you could add oral while you're giving the IV as well. The oral is going to work longer term to correct this deficit. So we're going to that's a consideration as well. And you're going to get lights frequently. You're going to get them every 2 hours for at least 2 times until things get a little better. And once you get your K to close to 3, then every 4 may make sense as well. You're going to keep an eye on the reasons why he's losing potassium. Most likely it's the furosemide, and we're going to make sure he's not DIG toxic. Okay, let's look at case 4. Is a 19-year-old female admitted to the emergency department with ketoacidosis after 2 days of nausea, vomiting, and polyuria. Her labs are sodium is 128, her K is 5.6, her chloride's 101, her is 12, her BUN is 35, creatinine is 1.8, has a blood glucose of 550. The urinalysis is positive for ketones. Blood gases indicate that she has a pH of 7.25. Which of the following is appropriate for her? Would you want to give her regular insulin? Would you want to give her normal saline? Do you want to get electrolytes? Do you want to give her K-exolate? We'll talk more about that in a minute, but do you want to get that potassium down? And do you want to give her bicarb? So a lot of this overlaps what we talked about in the management, or what we will talk about in the management of ketoacidosis and diabetes and endocrine block. So it's been, so we're putting you a little disadvantaged because there's some content here that we really have presenting separate from the endocrine block. But it is an important consideration for us. Let's walk through each of these for this patient. So what are we going to look at for her? We are going to start her on an insulin drip. The insulin is going to be titrated for her blood sugar, and our goal is going to get her blood sugar down slowly to between 50 and 70 milligrams per deciliter each hour. Because keep in mind that like with sodium shifts, glucose shifts also, water follows, and we want to be careful about not being overly aggressive with fluid shifts for her. Yes, we are going to replace her saline more aggressively because she is probably dehydrated from the nausea, vomiting, and polyuria for the prior 2 days with her ketoacidosis. And we're going to keep her on a pretty aggressive saline drip at 350 an hour until her glucose gets down to 250. Then we're going to switch her to D5 half normal saline with her situation, which is typical for our response with ketoacidosis. Yes, we are going to get electrolytes regularly. She needs frequent monitoring. And with her use of insulin, we're going to expect pH changes, and those pH changes are going to mean a shift in potassium. We are not going to give her K-exolate to lower her serum potassium because once we correct her acid-base balance and she becomes has a serum pH closer to 7.4, we expect that elevated potassium to shift intracellularly and actually continue to drop. It is likely she is total body storage of potassium is low, so we don't want to bind potassium in the gut. We actually are probably going to have to replace potassium. We also are not going to give bicarb, even though she is acidotic, because we're going to correct that pH imbalance with insulin and manage her glycemic control. It is not it is not appropriate in most cases of ketoacidosis to give bicarb solution. Okay, so some of the concepts here overlap other areas in the curriculum, but I encourage you to sort of try to walk through that and make logical sense of that. All right, that was hypokalemia. Now let's look at hyperkalemia. Typically, when folks have elevated potassium, it could be a function of kidney disease. It could be excessive potassium administration. We see this surprisingly frequently when we have someone who's hypokalemic and we over-aggressive in our replacement. There are drugs that actually contribute to hyperkalemia. The ACE inhibitors, the ARBs, spironolactone, even nonsteroidals can do that. And then we also, as we alluded to in the earlier case, acidosis would result in shifts of potassium extracellularly, which elevates the serum potassium level. So important to interpret any potassium level in light of serum pH. So the symptoms of hyperkalemia could be muscle twitching, nausea, cramps, paralysis, but our biggest concern is going to be cardiac. And depending on how high potassium goes, we'll see different cardiac changes. At 5.5 to 6, we might see peaked T waves. 6 to 7, we could see a QRS widening or a PR widening. Between 7 and 8, we may even lose the P wave, have slow conduction, and above 8, we risk ventricular fibrillation and asystole. So these are really concerning. And you remember when we said about potassium replacement, we don't ever give potassium IV push because what you see is a level above 8 with V-fib and asystole. Never, ever, ever. So the management of hyperkalemia, we typically are, if the serum level is above 7, we're going to probably give calcium IV every 10 minutes to protect the heart from hyperkalemic states. We're also going to look to immediately shift some of that potassium to in the cells. Even if the patient doesn't have a change in pH, we're going to give bicarb with insulin and dextrose and maybe albuterol to boot as part of our treatment approach to shifting potassium into the cell. This doesn't get rid of the total body potassium, but it buys you some time until the body can respond. If you want to enhance the loss of potassium, perhaps dialysis, or then we could use Caxylate, sodium polystyrene, 15 or 30 grams, either orally or as a retention enema. That will reduce bind some potassium in the gut and allow it to be eliminated to some degree. So what we're going to do for monitoring, typically we're going to get a serum potassium level every 2 hours until it's below 5.5. You want to get serum glucose levels also if we're giving insulin as part of our management. We want to look for patients who have acute renal failure to check their MAG, their FOS, to also review if there are nephrotoxic drugs on board, and if they are having acute renal failure, to also look at renal eliminated drugs and either get rid of them or reduce the dose of them. So let's look at case 5. TS is an 88-year-old female, 58 kilograms to the general medicine floor for community-acquired pneumonia. Her meds include lisinopril, ibuprofen, furosemide. Her serum creatinine is 2.4, which is a big jump from 1.2 when she, prior to admission 2 weeks ago at her office visit. Her serum K is 6.3. Which of the following are we going to do? Do we transfer to the tele unit? Do we hold her lisinopril and ibuprofen? Do we get lights? Do we give her calcium gluconate? Do we give her sodium bicarb, regular insulin with D5, albuterol, or Caxylate? Which of those do you want to do? So think about that. Yes, we want to transfer to tele because we're concerned about that high potassium with cardiac rhythm changes, so you want to get an EKG on her. Yes, we're going to stop the lisinopril and ibuprofen. They're common causes for acute renal failure, and also the lisinopril will contribute to hyperkalemia. Yes, we're going to get lights frequently for her, every 2 hours times 2, then probably every 4 for 3. Keep an eye on how we're doing. She probably only needs calcium gluconate if her serum potassium were higher or if the EKG suggested she was symptomatic. So calcium gluconate or calcium chloride at this point is probably premature, but if it were higher or if she was symptomatic, yes, we would. Bicarb only if it's an issue for significant issues, because we could change her pH and drive the drug intracellularly, but she's not, drive potassium intracellularly, but she's not that problematic. and the sodium load of the bicarb may actually make her heart failure worse. And why do we say, did we even say she's in heart failure? Well, if she's on furosemide and lisinopril, it's likely that she has heart failure. Regular insulin with D50, yes, that's appropriate. Albuterol, yes, that's appropriate. Sodium polystyrene, oral, yes, that's appropriate. So keep in mind that it's not necessarily wrong to consider giving her calcium gluconate. If she were really symptomatic, bicarb might also make sense. But those two are probably would be in sort of the back of our list unless she were fluidly symptomatic. Okay, let's move on to calcium. As we look at the nature of calcium, we think of this as mostly extracellular. It is involved in neuromuscular function, particularly related to the actin myosin, also cardiac function, and also it's involved to some degree with blood coagulation cascade, platelet adhesion, and it's impacted by the parathyroid hormone, vitamin D, and calcitonin. Normal serum calcium levels usually 8.5 to 10, which the total levels include bound and unbound. So if someone has low albumin, you may need to get an ionized calcium level to really assess where their calcium status is. And 99% of calcium is actually stored in skeletal bone. It's released related to the feedback loops involving the parathyroid hormone. So let's look at hypocalcemia first. Somebody could be hypocalcemic, low calcium, with malabsorption, inadequate intake, if they have a vitamin D deficiency, if the hypoparathyroid states, if they have pancreatitis, or if they have low albumin, they may have a total low calcium serum level, but you need to check an ionized level in that case. Symptoms of hypocalcemia include tetany, central nervous system changes, paresthesia, seizures. You might also see muscle spasms. You might see changes in mental status, depression, psychosis, impaired cognition. And on EKG, you could see dysrhythmias and QT prolongation. You could also see a predisposition to a worsening of heart failure. So the management is first figure out why the patient is hypocalcemic. If they have a low albumin, you want to get an ionized calcium, or at the very least use a calculator. Global RPH has one. There are other ones as well that you could use to correct to calculate a corrected calcium in light of their albumin. The formula is also listed here. You also want to check other electrolytes, including mag, phos. You want to look at their renal function, their creatinine, and BUN. You also want to look at their calcium phos product, particularly if they're in renal failure. So if the calcium and the phos levels, calcium times phos is greater than 55, they're at risk for precipitation of calcium phos crystals. So you want to keep an eye out for that. Now, if they're hypocalcemic, then you wouldn't expect there's going to be a problem giving calcium. But if they're very high phosphate levels, then yes, you would, because that calcium phos product would be very high. If they're symptomatic, we want to give them IV calcium gluconate. If they're asymptomatic, you can get by with just probably oral calcium, calcium acetate, calcium carbonate, vitamin D, and calcitriol. The etiology of hyperkalemia, high potassium. We might see hyperparathyroid states. Most often we see malignancy, or you'll see when we talk about in the oncology block, tumor lysis syndrome. Worry about that. But in malignancy as well, you'll see particularly bone mets. You might see a dramatic release of calcium from the bone, and that can become significant. You also can see hypercalcemia and renal dysfunction. Sometimes we'll see it drug-related. Most often, if it's a drug, it's vitamin D, excessive vitamin D intake. Sometimes lithium thiazides, or occasionally in hyperparathyroid states. The symptoms of hypercalcemia, high levels can result in confusion, psychosis. You can see EKG changes. You might see polydipsia, polyuria, nausea, vomiting, constipation, and when it's very high, soft tissue calcification. So our management is to address the underlying issues. And first, particularly if they're volume depleted, we're going to give a lot of normal saline, pretty aggressive normal saline, and we might follow that with a loop diuretic like furosemide, and monitor and replace whatever potassium they lose from that loop diuretic. Then the next step is whether or not they're a candidate for a biphosphonate. The older pimidronate was what we used to use. Almost now the only agent we use is zoledronic acid. Typically it's in the range of 4 or 5 milligrams over 15 to 30 minutes. Zoledronic acid, though, does require to be adjusted for renal dysfunction. So if someone has poor renal clearance, then that dose of zoledronic acid is reduced down to 3 milligrams or something between 3 and 4. And you can look at the compendium as far as dosing zoledronic acid in patients with renal insufficiency. All right, let's move on to phosphate. Phos, typically an anion, and most of it is intracellular. It is critical in membrane structure and enzyme activity. It's key in energy production. We think of ATP. P is the phosphate. It's related to the oxygen carrying capacity of hemoglobin, and its normal serum range is usually somewhere between 2 or 2.5 to 4.5. In hypophosphatemic states, typically we're worried about low phosphate levels in folks who have malnutrition or ethanol abuse. They might also have decreased absorption of phosphate by, usually it's a concurrent phosphate binder. They're taking a lot of antacids, sucralfate, or aluminum-containing antacids. They bind phosphate, and so they might be depleted in that. They could also have increased loss of phosphate by renal losses, particularly with osmotic diuretics, sometimes with the corticosteroid use. The signs and symptoms of hypophosphatemia: if the phos is above 1.5, usually it's asymptomatic. Where you see a problem is where you see levels below 1.5 or below 1. You might see encephalopathic presentation with irritability, weakness, and comatose type state. And you want to rule out, if they have a low phos and a high potassium, rhabdo, particularly if they have alcohol abuse or a risk for rhabdomyolysis, like a statin use or a recent fall. You can check the CPK, myoglobin, BUN, and creatinine. And the other issue you need to think about with hypophosphatemic states is refeeding syndrome. We'll talk a little bit more about that. But low phosphate levels, when we give dextrose or calories to patients, what you end up with is a situation where they don't have enough ATP to really, because of the very low phosphate level. And first we correct the phosphate before we look at giving nutritionals. So etiology of this we've sort of alluded to. Let's talk about refeeding syndrome and what refeeding syndrome resulting in respiratory failure can present like. So first, we have an increased calories we give to a malnourished patient, but they will then rapidly have an intracellular shift of potassium to start this metabolic process that they haven't used. And what you end up with is decreases in phos levels and decreased tissue oxygen delivery, which increases respiratory state compensatory mechanism. Then you see a decrease in ATP and energy stores, and ultimately to renal failure. And so in our practice, typically before we do any nutritional support for a patient, particularly if they've been malnourished for a while, we're going to get a phos level and replace their phos before we give them calories, and make sure we replace that phos pretty aggressively if we need to manage this. So the management in adults, typically if they are symptomatic, we'll consider IV phos replacement, or if it's below 1 to 1.5. And then if they're symptomatic, we need to stop any dextrose or TPN solutions until we get that phos replaced, particularly if they have respiratory symptoms. We could use sodium phos or potassium phos or a mix of the two, and there's some tables here for weight-based dosing based on what the phos levels are, and the dose usually is rounded to a standard dose. And IV phos will either use sodium phos or potassium phos, usually 15 or 30 millimoles and 250 of D5 is typically what we'll give as a standard solution if we give it intravenously. Now, I will tell you that over the last year or two, there have been national shortages of sodium and or potassium phosphate intravenously, and so that's been a nightmare for hospitals to manage, but we figure a way to do that. Sometimes we'll give the 15 to 30 mil equivalents at a rate higher than over 6 hours, but usually what we'll do is we'll give that over, for most patients, routine is to give 15 millimoles over 4 hours and a 30 millimoles over 6 hours. You also have to watch the potassium in the K-phos if you're using potassium, we'll watch the sodium and sodium phos if you're using sodium. So if they also have a potassium deficit, then K-phos is the way to go. If they're in heart failure, you may want to avoid the sodium phos, but you weigh that out based on what their other electrolyte balances are. For hyperphosphatemia, almost always this is related to renal failure, and we manage these with phosphate binders usually, but it could be related to something we do. For example, Fleet's enemas, phosphosoda enemas, have a lot of phosphate in them. Would want to avoid those in patients with renal failure. We could also have elevated phos in rhabdomyolysis or malignant hyperthermia, or as we talk about in the oncology block, tumor lysis syndrome. We also could see hyperphosphatemia and DKA, lactic acidosis, or we could see it with concurrent use of biphosphonates, or folks who have hypoparathyroid states. So the symptoms of hyperphosphatemia, typically you're going to look at ectopic calcification in soft tissue. The symptoms with a calcium phos product over 55 is a precipitation of calcium phosphate crystals, almost like a snowstorm in a snow globe kind of thing. These crystals will form, and basically they can ultimately, the precipitates can actually lead to risk for organ failure. So you need to watch that. And typically, patients who have phos levels above 6.5, when you don't correct them, they have much higher risk for morbidity and mortality, so we need to correct those. So hyperphosphatemia, the first thing you're going to do is to get a calcium phos product. And if that calcium phos product is below 50 or 55, then we can use a calcium binder with their meals. And we talk about this also in the renal block. You can use calcium carbonate or calcium acetate. More common calcium acetate because that's a little bit better, probably as a phosphate binder. That's routinely what folks will do. And we dose them with meals. We used to use aluminum hydroxide. We don't anymore because it accumulates in renal failure. If the calcium phos product is over 55, then they're a candidate for one of the other binders for phos, and we talk about this again in the renal block, is Renagel or Phosrenal or one of those agents that are reasonably appropriate to consider. Okay, let's move on to magnesium. Magnesium, primarily we look at magnesium as an intracellular cation, some extracellular as well. Normal mag level is somewhere between 1.3 and 1.9 milliequivalents per liter. It has a role in neuromuscular function. We're going to be particularly focused on the role of magnesium in cardiac. Also, it affects skeletal muscle contraction. It's a cofactor in ATP production. About 2/3 of magnesium is stored in bone. It's not all that well absorbed orally, so usually when we're in a fairly urgent situation in the hospital, we'll give intravenous mag, usually as mag sulfate. Also, the oral mag salts, mag hydroxide, typically cause diarrhea, which sometimes limits the use of oral mag as a magnesium replacement. It's also renally eliminated, so we're careful about how much mag we give to a patient in renal failure or a patient who's on dialysis. So hypomagnesemia, usually a function of decreased absorption, maybe malnutrition, maybe concurrent alcohol abuse, or patients who've had significant malabsorptive diarrhea. But we can also have low magnesium states with significant NG suctioning. And you can have increased excretion of magnesium with diuretics or with a few other drugs, particularly the aminoglycosides or cisplatin, sometimes also with cyclosporin. The symptoms of hypomagnesemia include central nervous system lethargy, confusion, even seizure risk. Cardiovascular, we particularly worry about atrial and ventricular arrhythmias, QRS flattening, flat T waves, and probably most critical, and it's the drug of choice in managing it, is torsades. Ventricular arrhythmia is associated often with drugs that prolong QT interval as well. Concurrent with hypomagnesemia often is hypokalemia and sometimes low calcium levels as well. So typically when somebody has a low one electrolyte, you want to get an electrolyte panel at least for sodium and potassium, magnesium, and calcium. So the management first is to identify any underlying causes and then consider oral supplements, even though they're not well absorbed, for patients if that's indicated. But keep in mind that the oral supplements may actually cause diarrhea. Typically, when we give it intravenously, we have a couple of different regimens we use depending on what our treatment is. And usually, for most cases where it's just a magnesium replacement in an otherwise typical med-surg patient, we're typically going to look at 1 gram or 2 grams and 50 to 100 of D5W over an hour or 2 hours. That's pretty routine. Where we give higher doses, though, is either tocolysis or in preeclampsia or seizures with eclampsia in obstetrics. And so that's pretty common to give 4 to 6 grams or even more. And sometimes we give whopping doses of mag sulfate in obstetrics. And also in torsades, we give mag sulfate at 1 gram or 2, and we'll dilute it as well, except that we'll give it much more rapidly. We'll give it over 5 to 20 minutes. The problem with rapid administration of mag is that it causes hypotension. So unless you're in an urgent situation like torsades, usually you'd like the luxury of administering it over an hour or so per gram typically. But if you're in a situation like someone who's having uterine contractions early or they're having torsades, we administer it much more quickly. Would monitor mag levels over the next 48 hours, keeping in mind that we give IV mag and the mag will distribute over up to 48 hours after dosing. And so even if we give a bolus dose of mag today and we get a level in 4 to 6 hours, 12 hours, even 24 hours, that might not have fully distributed, and so that might be actually falsely elevated. And you go back another 3 or 4 days later, and they'll still see that they're depleted in magnesium, need more replacement. The opposite is hypermagnesemia, and that can be often a function of either excessive intake or renal insufficiency. Sometimes there are other etiologies as well, but they're less common for hypermagnesemia. Typically, what you'll see for symptoms when somebody has elevated mag levels might be hypotension, and that can also happen during magnesium infusions. Sometimes bradycardia, confusion of central nervous system issues all the way up to coma and respiratory depression, but those are very, very high levels of magnesium if you were to see that. The management of hypermagnesemia in adults is to correct the underlying cause and to look at calcium gluconate as a cardioprotective, as well as considering having somebody on telemetry to monitor for that. And then if you're trying to preserve their renal status, you want to make sure they're adequately hydrated. You might also consider a diuretic with calcium as well. All right, near the end here, let's go switch gears and talk about electrolyte issues and parenteral nutrition and nutraceuticals we'll talk about a bit at the end here as well. So when we have somebody who's got parenteral nutrition, we'll talk a bit more about these parenteral nutrition solutions in a bit, but we're going to manage all of these factors when somebody who's got their only source of nutrition is intravenous, either peripherally or centrally administered parenteral nutrition. We have to monitor their fluid status, their electrolytes, all of which we've assessed here, and the amount of chloride or acetate we use in those solutions as which salts we're going to add to their nutrition solution is going to be dependent on their pH status as well. So the pH status, as we alluded to, typically if it's acidotic or alkalotic, based on where the patient stands, we may adjust which salts we use. As a sodium or a potassium salt, we may choose an acetate versus a chloride, depending on whether or not our goal is to affect pH overall. So we'll use chloride salts to lower pH, for example, if a patient's in metabolic alkalosis, and we'll use an acetate salt in their parenteral nutrition if we want to increase pH. So we kind of will titrate their electrolytes in their solutions that they get accordingly. All right, let's now talk about those nutrition solutions we'll use. There are both enteral and parenteral. And in practice, if you're working in acute care, you'll have patients who require enteral or parenteral nutrition, and that's usually managed by the clinical dietitian and the clinical nutrition service, but sometimes with input from the pharmacy. But as a clinician, you're going to have some involvement here as well. Also, if you're dealing with patients in long-term care or you're dealing with patients in subacute care, they may also be either on parenteral nutrition or more commonly, they'll be on enteral nutrition, and there's lots of factors to consider. So I'm going to give you sort of the pharmacist's perspective of these solutions, but there's other things to consider as well. So enteral therapy, typically it's a way to provide nutrients to a patient who has a functioning GI tract. And really, for anyone who has a functioning GI tract, it's almost always universal. This is where we go. We don't really go with parenteral nutrition for a patient when the gut is functioning and we can use the gut. Where we wouldn't want to do enteral nutrition is someone who has had a bowel obstruction, they've had uncontrolled vomiting, they've had very recent surgery for which you're trying to do bowel rest for some reason. But short of that, most patients can be managed on enteral nutrition solution. And then the modes of delivery depend on whether or not your short-term or long-term goal. With a short-term goal, you can do a nasogastric, nasoduodenal, or nasojejunal tube. But for longer term, you need a surgical implant for another tube that will then ultimately dwell, particularly where it's going to dwell. Usually in the jejunum is usually what we'll see. The schedule of administration, there are continuous infusions, there's cyclic infusions, intermittent infusions, or bolus administrations. Each of these have their advantages and disadvantages, and you're going to choose them based on guidance from clinical nutrition, but also what's practical for the patient. And you also have to think about whether or not the enteral feeding interacts with an orally administered med. And so while it is often considered to do a cyclic infusion, every 6 hours to give a bolus feed or something like that, if you don't time the meds that might bind to that bolus feed and affect the absorption of that med, then you end up with, if anybody changes anything in the timing, you affect the absorption. You see a lot of variation in drug response. So you need to be kind of careful of that. There are lots of ways we can administer enteral feeds. It can be by a syringe, by a gravity drip chamber, or by a pump. The components in an enteral nutrition are going to be really the same components we're going to use in parenteral, and they're the three macronutrients we think of: the amino acids, the carbohydrates, and the fats. Amino acids might be adjusted based on whether or not there are certain amino acids you're shooting for or not, based on comorbidities like particularly liver failure or renal failure. Carbohydrates are typically simple sugars that are somewhat calorie dense, and particularly fats are very calorie dense. And you're going to mix the choice of amino acids, carbohydrates, and fats to an optimal level with input from clinical nutrition about how to do that and how much of that to do. Other components are going to be in enteral nutrition include electrolytes, vitamins, trace elements, and probably one of the biggest risks for enteral nutrition is an aspiration pneumonitis. And so you need to be careful about what that aspiration risk is for a patient. particularly if they have a nasogastric tube of some sort, where that could be a risk for, and they have a risk for aspiration. So you need to watch for that, but that risk is still lower than maybe it would be if a patient were eating themselves. So in developing a plan, there's a couple of charts that we'll have through the nutrition section. I encourage you to sort of step through them, but they look at how you determine caloric requirements, which formula they'll pick at what calorie per milliliter. You also could need to consider volume that's going to be tolerated for the patient. You want to make sure they have enough of each component, particularly protein. And you want to also look at, depending on how much carb is added or dextrose is added to that solution, is that going to affect their glycemic index and their glycemic response if you need to monitor for blood sugar. In addition, the protein, you need to think about, are you trying to limit proteins because the patient has already albuminuria or something? So all of that is sort of managed pro and con. The routes of administration of parenteral nutrition, on the other hand, parenteral is limited to those folks who can't tolerate enteral nutrition and need nutrition, and usually in the hospital for patients who have not had enteral feedings for 3, 4, or 5 days, that automatically triggers a nutrition consult to evaluate whether parenteral nutrition makes sense. And then you need to look at whether you have a central line or a peripheral line. The problem with peripheral line solutions are that you can't get enough calories in an osmotically neutral or hypertonic solution that can be tolerated in a peripheral line. You can't get enough calories in that volume because you're usually limited to 2 or 3 liters per day. So you need to sort of keep that in mind. So the 3 components in a parenteral nutrition solution are amino acids, dextrose, and fats. And with a central line solution, we are capable of achieving really all the calories we need in that 2 or 3 liters because we can give more dextrose and higher amounts of amino acid because it's hypertonic solution, but that can be tolerated in a central line where that wouldn't be tolerated in a peripheral line. So the things we're thinking about here are the amino acids. First off is we'll look at what amino acids they need and how much, and that depends. The requirements as a default are recommended based on adults or children. So we'll sort of consider that. The complications might be elevated BUN, hepatic coma. The formulations might be specialized based on existing liver or something like that. And we need to be careful about the higher percentage rates of amino acids as they're hypertonic and have to be given only as a central line solution. For dextrose, these are non-protein calories. We need to look at glycemic control for patients, but it's a way to give a lot of calories. We often, in diabetic patients, have to adjust their insulin regimens with a TPN. Historically, we used to actually add insulin to a TPN bag, but we don't do that really much anymore because it makes it harder to titrate or adjust the dose once it's already in the bag. And its administration, the concentration of dextrose, if it is a concentration that is greater than 10%, even greater than 5% in most solutions, we often have to consider giving it by a central line, not a peripheral line. So we really opt for long-term management and nutrition support for a central line to get enough calories in a 3-liter solution for a patient because of its high osmotic pressure. And finally, fats or lipids are the most calorie dense of all, and we're going to look to give it as to either prevent or reverse an essential fatty acid deficiency in patients. But we need to be careful about how much fats we give and how we administer them. But that's also done sort of in a pretty standardized way. We're also going to look at in that IV solution to make up for what we think is going to be their potassium, sodium, calcium, mag, phos levels, and we're going to also make sure they have adequate trace elements and vitamins in those solutions as well. Often the parenteral solutions will contain either a mix of the dextrose and amino acids with the lipids given as a separate IV, or it could be given where all 3 are mixed in the same bag. So here are some of the osmolarity components associated with each of these components that affect whether or not the drug can be given centrally or peripherally. And the advantages and disadvantage of a 2-in-1. A 2-in-1 is an IV solution with just dextrose and amino acid, where we give the lipids separately, and a 3-in-1 is a bag that has lipids plus dextrose plus amino acids in it. And so there are advantages and disadvantages to each that are listed here. And then there are a few tables here that will list examples of calculating central parenteral nutrition and peripheral parenteral nutrition solutions. I encourage you to just let your eyes scan across these as a process that's done, but this is routinely done by the clinical nutrition service in most hospitals with partnering with the pharmacy, and then they'll present their recommendation to you with explanation of why they picked what they picked, and then you as a clinician can say a veto or say, yes, that's what we want, this meets the goals of this patient, or no, there's some other variable you know about this patient that those clinicians didn't, and you'd adjust accordingly. So you'll find which of the solutions, for example, they come upon which what the macronutrients are, and then they'll look at adding the micronutrients as well. Here's an example of a calculation for a peripheral solution. These are usually less calorically dense, and they don't even usually meet the full caloric requirements for a patient, usually because we can't provide enough calories to meet that need for that patient. All that a peripheral parenteral solution can do probably and achieve without a fluid overload is to stem the tide of, provide some calories, but usually not enough for what the patient will likely need. Further examples of that peripheral calculation. We also look at vitamins, and vitamins are added to the parenteral and enteral nutritions. They're organic compounds. They're needed for some usually some metabolic or essential process in the body. And so each of these vitamins will go through some of these, and these can be given enterally or parenterally. Most people who take a multivitamin, for example, contain most of these vitamins. If someone's diet is good and they're eating lots of, vegetables and fruits and other sort of standard things in a good healthy diet, they probably don't need supplemental vitamins at all. But a lot of Americans who don't necessarily eat as well as we should, many of them will find that a multivitamin sort of is a little bit of insurance, perhaps, that they're not going to have a deficiency in one of the more common vitamins. So vitamin allowances are periodically updated, and the recommendations are usually looked at a recommended dietary allowance or an adequate intake. There are a couple other different ways that we may look at those allowances, but most of the time they're posted on, and labeling requires the manufacturer to list what the amount of each ingredient in a multivitamin is and how that compares to what a recommended daily allowance is, what percentage of the daily allowance is achieved by a single dose of that multivitamin. So let's first look at the fat-soluble vitamins, and then we'll look at the water-soluble vitamins. The fat-soluble vitamins are vitamins A, D, E, and K, and let's talk a bit about each of these quickly. Vitamin A, or retinol, has multiple functions. We kind of think of vitamin A as having a role in allowing the eyes to adapt to dim light and to maintain skin and mucous membrane integrity. Typically, sources include fatty things like butter, eggs, milk, liver, and drugs with high levels of beta-carotene, such as carrots and, to some degree, tomatoes, spinach, and pumpkin. The units are listed here. The typical minimum daily requirement is about 1,000 to 800 to 1,000 units, and or equivalents, and it's fat absorbed. And these issues we think of is that the fat-soluble multivitamins, or the fat-soluble vitamins, when they're administered, will stay in the body a long time. So you can actually become toxic in any of the fat-soluble vitamins by intaking too much. So we need to be careful about that. Deficiency of vitamin A can lead to night blindness. We can also see other complications associated with it, including skin lesions and changes in mucous membrane. But we have to keep in mind that vitamin A derivatives, particularly in high dose, are potentially teratogenic. And so we need to worry about, for example, a standard multivitamin is not going to be teratogenic, but a woman who goes to a nutrition center and has these mega doses of vitamin A, that could be potentially teratogenic, and we need to be careful about that and avoid excessive amounts of vitamin A. Therapeutically, we usually use it just to correct the deficiency. Under the derm section, we talk about some of these vitamin A derivatives for treating, among other things, acne and some other dermatologic conditions as well. Beta-carotene is a converted to vitamin A, provides for skin health as well as probably some eye health as well. Let's go on to vitamin D that we've talked about, or we talk about in the renal block here. But vitamin D is important in the regulation of calcium and phos levels. In children, it causes rickets. In adults, osteomalacia, deficiency of it does. And excessive amounts are also problematic in that they're fat soluble, they accumulate, and they can also contribute to a risk for hypercalcemia. Vitamin E, the role of vitamin E in humans is less than fully clear. There was believed at one point about a decade or two ago that vitamin E was essential for cardiac health. And we even had cardiologists often ordering vitamin E for their patients. But the data for that is scant at best. And so we basically don't see that as a routine practice anymore. It probably has some antioxidant properties. I think that most clinicians would say, look, if you're getting a diet that has an adequate amount of vitamin E in it, or you're taking a multivitamin that has a little vitamin E in it, you're probably perfectly fine. Vitamin K, particularly related to clotting factors. We talk a bit about this. We talk about warfarin and coumarin when we talk about the antithrombotics. There are lots of sources, but we usually think of green leafy vegetables as a source, and it will maintain the production of clotting factors in someone who also has a functioning liver. So vitamin K, sometimes for folks who are in liver failure, particularly liver failure secondary to alcoholism or some other condition, we sometimes see that patients will get doses of vitamin K when they come in the hospital if their INR or PT is high, just to confirm that the reason that their INR is high is not related to a vitamin K deficiency. So we often will see that done. Most of the time the vitamin K doesn't really do much because the reason they are having an elevated INR is they're not making clotting factors because of liver dysfunction, not because of a deficiency in vitamin K, but because vitamin K is required for clotting factors, we sometimes will give a supplement dose. We also give a supplement dose in newborns at a lower dose of a milligram dose standard as a routine process at birth. It's orally requires bile salts for absorption. Its deficiency can include bleeding tendencies because of clotting factors or some other issues, including obstructive jaundice, which is correlated with vitamin K issues. But typically, in most cases, other than a single dose in a newborn or the use of vitamin K around folks who are on vitamin K antagonists, like warfarin, you typically don't see too much vitamin K used. Adverse effects may be hypersensitivity reactions, particularly when we give vitamin K IV. And so we limit IV vitamin K to folks who have severe coagulopathy secondary to warfarin overdose or warfarin overshooting where there is a clear bleeding risk. And then therapeutically, we've alluded to some of the uses of vitamin K here, both here, and the use of vitamin K in the antithrombotic block. Onto the water-soluble vitamins, typically the B vitamins and vitamin C. They differ from one another, but they're all pretty water-soluble. So I've heard people sort of anecdotally joke that if you could have an expensive formulation of vitamin B's and C's and you spend a lot of money, and what you end up with is expensive urine, because basically most of these drugs are cleared in the urine. And for the B vitamin complexes in particular, folks may notice that after they take a vitamin supplement with a lot of B vitamins in it, about an hour and a half later, their urine is sort of bright yellow. And that's because many of these vitamins are going to ultimately be cleared in the urine because they're relatively water soluble. So let's first talk about vitamin C. Vitamin C has multiple biochemical reactions that it's involved in. Its sources include citrus fruits and juices, tomatoes, potatoes, other sources as well. Deficiency causing scurvy and adverse effects in large amounts can cause diarrhea and maybe even crystals in obstructive kidney failure could be a possibility with very high doses of vitamin C. Typically what we're going to see is a dose of usually 500 milligrams to a gram a day for folks who are deficient in vitamin C. And typically if folks have an adequate diet with at least a little bit of citrus in it or tomatoes in it, they're probably fine and don't have a deficiency of vitamin C. The data for vitamin C, before we as we go on to niacin here, but let me go back for a moment. The data for vitamin C is limited in preventing coughs and colds, so the data is equivocal there. Over the last 4 or 5 years, there's been a lot of discussion about whether vitamin C or ascorbic acid has a role for patients who who are in the hospital in the ICU with septic shock, and the data for ascorbic acid IV in such patients is evolving, but the data is probably not particularly solid. So you'll see a lot of debate about vitamin C or ascorbic acid in sepsis in its management, and the data, just let's leave it at this point, is that it's evolving but not solid. All right, on to niacin. Niacin lowers cholesterol levels, and it lowers particularly triglyceride levels, and historically was an agent of choice for elevated triglyceride levels in patients. The problems with high-dose niacin is associated with a lot of flushing, not well tolerated for patients, but a little bit of niacin is a necessity. And so we typically see low to modest doses of niacin well tolerated for patients, but high doses of niacin that we used to use in managing hyperlipidemias, particularly hypertriglyceridemias, are associated with a lot of flushing reactions and even some perhaps liver injury at very high doses. So the deficiency of niacin or nicotinic acid when it's severe could lead to pellagra or other GI or CNS problems, but it's generally only a modest dose is needed to really correct that. Vitamin B2 or riboflavin has a multiple sources in animal and vegetable products. It's excreted in the urine. So one of the things that will cause that bright orange or yellow urine after taking a multivitamin with B, particularly B2 in it. It's only for the prevention or treatment of a deficiency, which isn't really well seen. Typically what you'll see in a very deficient state might be a sore throat or something else, but typically in not all that widespread deficiency is not all that widespread. And then there's some data about whether high doses might prevent migraine headaches. The data for that is not what I would call solid. It's not a universally accepted modality to give vitamin B2 to prevent migraines. Thiamine. Thiamine, you will see thiamine used extensively in healthcare. And we use thiamine particularly for patients who might be deficient in thiamine, and that's going to be particularly folks who come in with poor nutrition, often secondary to substance abuse, particularly alcohol induced states. If folks have a history of alcoholism, they often will not have a concurrent malnutrition, be thiamine deficient, and then they cannot metabolize carbohydrates well. And so thiamine deficiency poses significant risks we'll talk about both here, and we'll talk about under the management of acute alcohol withdrawal. Thiamine is associated in lots of plant and food sources, particularly pork, in peanuts, asparagus, a number of cereals. Deficiency can include wet beriberi or dry beriberi, but most often in alcoholism, what we think about is Wernicke-Korsakoff syndrome and other central nervous system manifestations, which can result in serious brain injury, so we need to be careful about that. And we never want to give dextrose or carbohydrates to a patient who we know or highly suspect could be thiamine deficient until we give them thiamine. So it's almost universal. Someone comes in with a history of alcohol abuse, we'll give them something like 100 milligrams of thiamine, IM or PO twice a day. If we really think they're thiamine deficient, we could give them 500 milligrams of thiamine, IV or IM or PO. But typically, we often give as a routine protocol someone coming in with a history of alcohol withdrawal or question of alcohol ingestion that's significant over time. We routinely give them thiamine, at least 100 milligrams twice a day, before we actually give them any dextrose. Vitamin B6 is found in animal and vegetable foods and milk and meat, soybeans, and other grains. And it typically requires a certain level of metabolism, and it's involved in metabolism of amino acids and proteins. Deficiency in a poor diet could be problematic in a number of cases, but really the medicine that I think of most often where we give pyridoxine to prevent nerve injury is isoniazid. Isoniazid in the management of TB we'll typically use to prevent neuritis and other issues related to nerve conduction problems. It also might interact with patients with Parkinson's who might be on levodopa, but that's usually not clinically important. And we use it to prevent or treat vitamin B deficient states. Most importantly, we'll give pyridoxine for patients who are on isoniazid to prevent nerve injury. B6 is involved in generation of amino acids and cellular function, but also in nerve conduction as well. Cyanocobalamin or B12 and folic acid, we talk about both of these a bit in the hematology block when we're talking about factors related to the development of red cells. And so for folks who are anemic, usually, particularly if their cells are larger in size, they have a large mean corpuscular volume, then we usually do an evaluation of whether or not they could be folic acid deficient or cyanocobalamin B12 deficient. And B12 deficiency typically is manifest by this anemia, and typically folic acid deficiency is manifest by nerve deficit as well as anemia. So typically when you look at replacing B12, you also just want to make sure that you're not masking folic acid deficiency as well and make sure you've got sort of both on board. The issue with folic acid deficiency also can be a function of, in a woman of childbearing age, a risk for developing neural tube deficits in a woman early in pregnancy for that fetus. And so we need to make sure that folic acid supplementation is adequate for a woman of childbearing age. So B12 and folate also have some issues as we look at patients who undergo coronary angioplasty. And there's some data that whether or not B12 and B6 and B12 and folate may reduce the risks for cardiac events. This is a small study done 15 years ago, but I think it's the kind of studies that we look at is we just want to make sure that folks have just the adequate amounts of vitamins, and there may be correlated outcomes that affect health that we haven't really measured all that well. And the only reason I include this slide is not to get aggressive about it, but just to consider that nutritional deficits are hard for us to recognize what the true implications are, because we can't always control for that one nutritional deficit or that supplementation very well. And because there's not a big pharma incentive to do these expensive studies well designed, we really don't have them. So I think the bottom line is just making sure that folks have a adequate nutritional support is a part of a bigger picture of our cardiac event risks and other health risks. Pantothenic acid, also found in many multivitamins. Usually we don't measure levels or dosing, but it's contained in a multivitamin and responsible for some types of synthesis biochemical processes. Similar for biotin, involved in metabolism of carbohydrates and fats. So as we alluded to already, folic acid important in avoiding certain types of anemias, but also in as it affects nerve conduction and nerve development in a newborn fetus. It's typically found in grains. In fact, most flours in North America are supplemented with folic acid to prevent this as a folic acid deficiency. Chromium as a trace element helps in fat and insulin effects in metabolism. Typically, we'll look at a low to moderate dose being effective for that, and it can result in better glycemic control. So you'll find, for example, in a lot of complementary alternative meds, there's a combination, for example, of cinnamon and chromium supplements for folks who have early metabolic syndrome, where they might get a little bit better glycemic control with a little bit of chromium on top of use of cinnamon as a complementary alternative approach for perhaps forestalling the risk for diabetes for a patient at risk with metabolic syndrome. Fish oils, we talked more about fish oil and omega-3 fatty acids in the hyperlipidemia section. Primarily, it's most effective at lowering the risk for hypertriglyceridemias. Selenium found in soil or in dirt, but it's found in lots of other foods and vegetables as an antioxidant that may be associated, among other things, with reducing cancer risk. And zinc has many enzyme functions associated with it, and typically what's involved, it probably believed to be involved in helping in, among other things, wound healing. So you want to make sure that folks have adequate zinc in their diet as well. The data for a multivitamin a day depends on which study you look at. Here's a study that's somewhat dated now, a decade and a half old, but looked at comparing, not a big study, not a rigorous study, but looked at multivitamins in patients age 45 or older, and their risk in the vitamin group for infections were lower than in the placebo group. Now, what you can't really tell from these small studies is, because it's hard to really know the methodology of how well that really was done in a fairly small sample size, how really true that is. But I think the bottom line is that multivitamins are relatively inexpensive, that if patients don't find a pill burden is problematic, a multivitamin is a routine process for people who don't really have a great diet, probably won't do any harm for a patient if it's a standard multivite that doesn't have excessive amounts of fat-soluble vitamins. Here's another study that looked at multivitamin use in patients who were older in nursing homes, and basically their assessment was that it offered probably maybe some benefit, but there was really no difference in this cohort of infections or emergency visits or hospitalizations or anything else. So it depends on the study you see. You're not going to find great data for multivitamins. I think it almost is a sense for a personal health choice for an individual about whether they take a multivitamin or not, but don't put too much stock that a multivitamin is going to do a lot for patients. Okay, as we wrap up, in the renal block, we talked about some of these, but we alluded to them again today. Importantly, you recognize the typical dosing and management of calcium and potassium chloride, and our fluid electrolyte drugs and doses, where we expect you to sort of understand or have an appreciation for normal labs and normal doses listed here. I can't reiterate enough that at least for these really 7 labs on the right-hand column, it is our expectation, particularly at this point in the curriculum, that you are really fully aware of what normal labs are for each of these. So if you would get a test question, for example, that had just gave you their result for potassium level, you could interpret whether or not that was hypokalemia or hyperkalemia or normally what you would expect for that